everybody, welcome to Ask the Anabolic Doc, starring Dr. Thomas O'Connor, brought to you by his websites, metabolicdoc.com and anabolicdoc.com. You can get this book there. It's called America on Steroids, A Time to Heal, also available on amazon.com. Joining us all the way from Hartford, Connecticut, Dr. Thomas O'Connor.
What's up, Ron?
Doing well, sir. How about you?
Excellent. Another beautiful day.
A little rainy. You don't got rain down there?
Yeah, it's rainy. Yeah, it's rainy here in Connecticut.
Okay.
Yep.
Let me use my proper grammar. You ain't got no rain down there? Okay. So I want to, again, copy another one of your videos because, guys, if you want questions answered, leave some questions here. Don't just keep telling the doctor to make more videos about this and that drug. Come on. Give us some questions. So today we want to talk about anastrozole, which goes by the trade name Arimadex. I always refer to it by the trade name. Very popular drug, used tons and tons of men who are recreational bodybuilders, competitive bodybuilders, and a ton of guys who are on TRT, more so guys who are on TRT through aging clinic, anti-aging clinics, which
you're right.
We'll get into because I got a buddy who's been on it for many years because they just gave it to him because why not? So your video, as again, it's on his channel, Anabolic Doc, notated, it's more scientific, but I'm going to summarize that, and then there's also, you had a couple questions and comments under that I'm going to have you respond to, if that's okay. So, anastrozole was developed back in the 90s, so it's one of the newer drugs. Some of the ones we're talk about are almost 100 years old. So it was developed, people use it to control the androgen to estrogen ratio. It limits the estradiol count, but it was developed to treat breast cancer. And it was actually found to be superior than tamoxifen, aka Nolvadex, which is another highly used anti-estrogen drug by bodybuilders. So the actual medical uses for this drug are, of course, it's an anti-estrogen for chemo for locally advanced or metastatic breast cancer. So I also found references online that said it's specifically used to treat postmenopausal breast cancer. Is that right?
So it used to be, and then now it's just breast cancer, because some women have breast cancer when they're before menopause, right?
Yeah, I mean.
So it was initially for that, and then I'm not a hematology oncology expert, but I believe that it's more broadly used now as it's an add-on chemotherapeutic. If you have those estrogen receptors that are positive, and most breast cancers are women. 99%, 1% are men, and most is estrogen sensitive. Most is estrogen positive receptors, but that's why they do biopsies. You have hematology, oncology, and breast surgeons. This is this is the team. It's again, it's mainly women, but this is what they do. This is what they do.
Also used for men with low T and high estrogen. We'll get to more about that later.
Off-label.
Off-label, yeah. That's an off-label use because it liberates free testosterone. It takes your estrogen down. But as you say, it's not sustainable. It won't have that effect forever.
When it's in practice, like 2005 and 2000, by 2010, I saw men coming in. These are just low T guys, not steroid using.
Right.
And they had low T, and everyone was looking at that study where they were older guys. They have diabetes and pre-diet, they have low T and their estrogen was elevated high. So let's look at lowering the estrogen conversion, and therefore it will liberate and increase their T on paper, and it does. But when you look at the guys, and I've tried it on a bunch of guys, maybe a dozen or so, not much more, because we would just go right to testosterone, of course. And the guys on paper would look better, just like the studies. There were more case studies. This is not randomized peer review. This is not big studies. They were kind of random case studies, but they're out there. And these are men that are like regular guys. They don't want to be on testosterone if they don't have to be. Hey, doc, let's try to block the estrogen. It seems great on paper. It never worked out more than 6 months or something. And then we would just stop it and go on regular testosterone. Either, a lot of these guys just want the gel or injections, and there you go.
You had a comment, we're not going to answer it, but some guy was asking what you thought of the scrotal cream. I mean, who the hell even, do they even make that anymore?
They probably do make it, but we don't use that, sir.
Yeah.
You know, doctors, you know, that are legitimate doctors that are treating men with low testosterone in the world, we do mainly injections and libido, you know, that 3-month injection, 2 months in America, 3 months in Europe.
Yeah.
Is used. It may or may not be helpful. The pellets are used, and then we have different types of formulation of cream and gels that can be compounded. It's not all androgel. There's a nasal nose injection. It's comical.
Oh, wow.
I don't think anyone really uses. And then there's Axiron, where you put testosterone on like a deodorant.
Oh, okay. So
Yeah.
You smell fresh too. No, I remember was there a patch that you had to put that on your scrotum.
Yeah.
Is this right? Is this true? And then you had to use a hair dryer to melt it on, which
I've never, you know, I love to say I don't know something. I don't know. I've never used that.
Yeah.
And then there's, but I saw it though. I saw guys coming in, Doc, look at this, and they would show it to me. Okay, how do you feel? I don't know. And I didn't end up. He came to me because he's not feeling good on it, you know, and DHT conversions and direct, and then you have just. I had this guy who was 103, and we had a little patch right here. We had a 103-year-old guy on testosterone since his 90s, and he died about 100. Well, you know, I actually left the practice I was in, so my partner took care of him. But he might have lived to. He could be still alive. Maybe he's 110 now. He was 103, and he was on testosterone, and it was the patch. I remember it was right here. It was a transdermal androderm, and his testosterone levels were like 700, and he was like, funny enough, I get little erections, but I have nothing. I can't do anything with it. You know, he was a great guy.
Oh boy. Okay, so the final off-label use, and you got a little heated when you talked about this in your video. It's used by anti-aging clinics, widely used, almost universally prescribed.
I'm going to punch them in the face.
Whether you need it or not, they're going to give you a Arimadex.
It's right.
Because, like, I asked my buddy, because
cookie cutter
years ago, I keep referring this guy. He gets his stuff a place in Florida, and I looked at the list of stuff that he gets every month. I'm like, why are you on the Arimadex? He goes, I don't know. They just give it to me, so I take it.
Same stuff. I got crazy on that. So Big Lenny, I know I'm getting pretty famous when Big Lenny made a.
Do you know who Big Lenny is?
I do know Big Lenny's the older guy that's on gear with the belly, and he's a pretty wild guy. Big Lenny, isn't Big Lenny like?
Yeah, he's one of the. They call him the Del Rey. You know, first it was Jason Genova. He's the star of that whole scenario. But then all the other wacky characters around him became known as the Del Rey Misfits. And Big Lenny's almost maybe as famous as Jason at this point.
Wow. Well, he was in the hospital a few months ago, wasn't he? He's okay?
Seems like every few months he goes to the hospital and, you know, death is knocking on the door, but he doesn't let it in. Yeah,
well, come on, Big Lenny. Thank you, Big Lenny. Thank you.
Lenny's hard to kill. Absolutely. All right, so let's get into these side effects because they're pretty bad. So it seriously crashes your HDL, the good cholesterol.
It does.
And if you're using this in conjunction with steroids, as most people are, your HDL's already tanked. So this must take it down to pretty much nil.
We saw it today. I saw it with my med student today. We saw a consult a few hours ago. I did a consult on FaceTime. I do consults all over the world. Yeah. And the guy's HDL was 26.
I mean, what's the lowest you've ever seen?
0, undetectable.
Okay. No negatives? No, can't do that.
Undetectable, and who knows what it really is. But I've seen many single digits. Yeah. And a lot of guys like this guy today, who's on 1 milligram a day from the anti-aging place. I don't even understand. 1 milligram a day.
Wow, that's a lot, right?
Oh my God, that's ridiculous.
I mean, the standard dose is 0.25.
No, the standard dose is 0.5 milligram, maybe 2 or 3 times a week. Which I'm not saying you can use it that way, but you just can't leave a guy on that, and it will lower the HDL in every single man. And if you have a cardiac history or a risk for cardiac disease, why would you want to do that to yourself?
Yeah, you said there's been cases of men under the age of 40 using Arimadex having heart attacks.
I have multiple. Well, see, it's a selection bias here. Men come to me on steroids and they have heart attacks already because they have bad. Look, that guy Matt Porter died from heart failure. It looks like. And that's like
pneumonia or heart failure.
Was it pneumonia? I have no idea. I'm going to wait till I don't want to get the haters hating too much, so I don't want to feed the bears too much. But he looks like he had early heart disease. Unfortunately, he had very bad risks. He had bad genetics, and then he put it on steroids and blah blah blah. Yeah. He went back on stuff, and then the aromatase inhibitors. That to me is just like it's like side. These are just like the steroids are the main problem, obviously, for lowering HDL. Aromatase inhibitors are just going to further lower. There's a black box warning on it for women for heart disease.
Yeah.
And
they're at a lower risk of heart disease than we are, as it is.
Correct. That's an interesting point.
Okay, so we know that that's a definite thing that's going to happen to you if you're using Arimadex or anastrozole. Mood, well-being, and CNS effects. Fatigue, depression, and if you already have depression, it's going to make your depression even worse.
Guys feel horrible on this across the board.
And as you pointed out, even if you're looking at their labs and their estrogen is fine, everything will look good on paper, but like you said, you always ask them how they feel, and a lot of these guys feel awful.
So the guy today, he feels good sexually, and he's on it from anti-aging place. He's only in his 20s, and he's just they put him on. They put everyone on it. You could be 9 years old, and they'll put you on testosterone.
Oh boy.
9 years old, you have to go higher. You have to be optimized.
Huh.
So so this guy feels his joints are achy. I know we're jumping over but he feels horrible, and I see so many men, but his estrogen levels look good on paper.
That was the next thing. Libido is often lowered over time. And people actually in the comments on your video reported a lot of that.
See that?
So it's not as uncommon as,
No, I knew that video would the comments would just come right out to support everything.
Yeah, every video you make, somebody will say, yes, this is what happened to me. Actually, not one. There'll be like 30 or 40 or 50 people that say, the doc was right. I did this. I took this, and this is exactly what happened to me.
I mean, I'm making these videos because I have the history after years and years of this, and there's no other doctor, and I don't know, Dr. Rand maybe is a guy, I think Dr. Rand is out there, he's legit. Yeah. And I don't like these anti-aging guy, I don't like anti-aging word, right. But he's out there with me, and Dr. T is out there in Greece, and there's other doctors, but I'm just trying to broaden the world, right. Because the anti-aging doctors, I'm sorry guys, that's ridiculous. If you want to anti-age, don't have a heart attack.
Hot flashes, another side effect.
I've seen it. So many guys.
I don't even know. I don't even know what that would be like, because it's typically something you think of as a woman going through menopause. But it sounds.
Face is they're just burning up, and it's because that's when the estrogen is really, really low.
Okay, so hot flashes, musculoskeletal effects.
Big time.
So for the men, women have issues with the bone density, osteopenia, osteoporosis. Not so much men, as far as you could tell from the literature. But this is a scary one for us lifters: tendon and ligament injuries. You'll be having more tendon and ligament issues, tears, I would imagine.
But that's so anecdotal, and that's why powerlifters. And I learned this early on, over 15 years ago, 10 years ago. Powerlifters, we don't care if we're puffy. We want puffiness. We want our joints to be puffy, right?
Right.
Because we're benching big. We love D-ball and Androl, right? Because it's like, I want puffiness in my joint because it protects the joint.
Right.
So no powerlifters use aromatase inhibitors.
No, I mean, why would
they? Don't check estrogen levels, and they're horny, and they feel. It's just interesting science. It's an interesting.
You're gonna get me jealous because I'm not a powerlifter now. It sounds like they get to eat what they want and whatever. Hair loss, GI effects, and effects on your hair and nails. You can get nail fungus. The hair loss. I mean, how common is that with this?
No. My main. I did the main ones. Which is the heart, the mental status changes, and then you have the bones and ligaments and tendons. So those are that's the real money. And then just for being thorough, I thought in my brain, like, what else have I miscellaneously heard? Okay. And guys would come in, doc, aromatase, don't take aromatase inhibitors. I lost hair. I had nail fungus on my toes and weird rashes. And honestly, I don't know.
Yeah,
that's
maybe connection, maybe no connection.
But a hair loss. But wait a minute, should we blame all the testosterone you're on? I'm just saying.
Yeah, I mean, if you're on 10 different things, like I always say, how do you know what's doing what to you?
The main thing is, again, the heart. It's every single guy is going to lower the HDL. every single one. How much risk is it going to take, and how bad is that going to be for you? That's all man for man.
Right. So your rationale for use, this is when you would use it. Last resort. You don't give this to everybody in your practice. You would only use it in men who have no history of heart disease, and you would run all the proper tests, the calcium score, the blood pressure, stress tests. I'm sure HDL, you'd want to make sure all that was fine. With
family history, they have to look good.
Yeah, and you would use it for steroid users, or probably younger steroid users who haven't developed ASIH yet, so they can come back. So you'll use that as part of their anabolic recovery phase.
Try to get them off.
Which is crazy, but I didn't even realize there are people like that anymore, but I guess there are. You would adjust. Yeah, this is the thing. You've talked about this many times, that if you just change the way you take your testosterone and microdose it, instead of doing 400 milligrams all at once or whatever, you will avoid a lot of this aromatization, and there wouldn't be a need for.
My patients have taught me that, Ron. My patients, I learned that from my patients. They're like, Doc, you can't. Don't you know you got a micro? This is probably 5 years ago that came into favor, because guys they don't feel good on the aromatase inhibitors. The common sense is they want to keep it to a down low. They don't want steroids. They just want to have a nice high level of testosterone. They don't want it to go up and down.
Right.
And then, so microdosing, and I learned my best stuff I learned on a couple guys that are very young, under the age of 40. They had heart attacks, unfortunately. Part of the reason was because they were on, obviously, bad genetics, testosterone, recreational drugs. We can leave it, that might have pushed one guy over the edge, but a lot of guys do cocaine, when they're in Miami and they're chilling out, and they don't have, there are no heart attacks going on. So the guy had bad genetics. He has a heart attack. They put a stent in him. And then when he came to me, his HDL I saw from the hospital, from even after, was like in the teens. And I was like, sir, what else are you on? He was like, I take the Anastrozole, Arimadex. Well, how much do you take? I just take it once. I just take it like as I need. I just take it when I feel like I need it.
Oh.
And I was like, oh, okay. So I was like, well, that's why your HDL is so low, and you had a heart attack, and you have a stent placed, and you're only like 28. Oh, so I was like, we should not do. But Doc, I need testosterone. I got to keep my estrogen down.
That's true.
I was like, okay. So, but this is a couple years ago. So he was like, Doc, let's do the microdosing. I was going to do tamoxifen. Even that, I was nervous with all this. So he microdoses, and if he's watching right now, I did learn a lot, and I've done this on a lot of other guys since that. Yeah. Dozens and dozens of guys, if not even maybe a couple of hundred, maybe, because I have a lot of, I see 2 or 3 new. I'm getting like 2 or 3 new patients a day. I'm not sure how I'm still functioning right now.
Oh boy.
So it's awesome. So basically, we take little doses, like 0.1, like 10 to 20 milligrams even, every day or every other day, and it just, I know, it's
you're never going to get jacked like that. Let me tell you right
they're
now.
not. He's not looking to get jacked. He's looking to have He's looking to have good sex.
All right, fine.
He's looking to have good sex, and he's looking to go to work. And he's got a good body, though. This guy, but he's definitely an aromatizer. He's very sensitive to estrogenic esters, not to mention D-bol and anadrol, and he don't want those anymore. He just wants to feel good and not be puffy and not have gyno, and he likes his brain so he doesn't feel weepy and have great sex.
So let me ask you, the standard dose for TRT is 100, 200 milligrams a week. That's what most guys legitimately are on. On that amount of testosterone, do most men have any need for an anti-estrogen?
Oh, not really, truthfully. But if you look at the levels on paper, most guys, depending on when they go to the lab and what technical dose they're on, if you measure an ultra-sensitive estrogen, not to mention a total estrogen, it will be a little elevated. But some men really do Ron, some men are massive aromatizers.
I'm telling you, I've done 2-gram cycles many times over the years, 2 grams a week. I've done many cycles that were a gram of test as the base. Never used any kind of aromatase inhibitor, and I never got gyno.
Isn't it incredible? Isn't it? And these are guys.
Hair's still here. Yeah.
And these are guys that are doing TRT doses, and they're getting wild about their side effects, and I'm not putting them down. I'm not disagreeing with them.
Right.
How do I disagree with someone's opinion? I can't.
Okay, now you did have one good question. This was right under your video. The top comment / question. Please ask Dr. O. Since the brain has its own dedicated aromatase enzymes and areas of the brain that contain higher concentrations of these enzymes, do you think it's possible that estrogen conversion is controlled to a greater degree within certain brain centers, controlling things like sleep, memory, mood, and sexual behavior? My concern is that by measuring serum estrogen levels and dosing anastrozole or aromasin accordingly could lead to possibly overdosing these localized area in the brain. For example, using a suicide inhibitor like aromasin could deactivate permanently the enzymes in critical areas of the brain that modulate sleep, mood, and memory. If the enzyme turnover locally is different, for example, than systemically, is this guy a doctor? Such as in excessive adipose tissue, could it also not be long before the CNS is now inadequately converting androgens locally? Did you get all that?
I did. I saw that, and I'm glad you picked this one up. So that's a great question. This is a very bright man. He's definitely a bro scientist. So what do? I always tell guys this. We're measuring the blood from a vein, typically right here.
Yeah.
But we're going to look at that value to make a change for in here or in your breasts. So can we draw directly out of your brain? I mean, so what the guy's saying is correct, actually. The aromatase inhibitors, we know the central nervous system is very complicated. There's dopamine, norepinephrine, antidepressants. There's serotonin, estrogen, androgen. We're men. We're not the smartest creatures in the world. Women are more bright. No one's going to argue that. They think better than us, right? No one's going to argue. We're kind of knuckle dragging yard apes. When you give a man testosterone, he feels hornier. Most of us. Why? Because the androgens going into your brain and you feel, and then forget muscle building. So there's no question that there's a balance going on, and you can nail the balance down by looking at looking at your peripheral blood and intuiting, but then no guy ever stays the same. Then doc, I lost the effect. I had it and then I lost it. I don't know what to do. But that's why I'm the anabolic doc. I mean, testosteronology guy. So he's right, but your brain is always changing. And it doesn't stay the same. So the average bear, we take testosterone. God knows if you need it. Only if you don't need it, don't take it. And then your brain feels pretty good, right, Ron? Look at you. You feel, you just look good, feel. But you know, Ron, we don't have depression.
Yeah.
These are guys that I call them, they get squirrely, and they start reaching and trying to focus on tangible things like estrogen. And I'm not saying it's not right. That's why I'm doing my studies. I'm going to make a big announcement sooner or later, probably in the next month. Okay. Big announcement coming up, research. So you know what? We don't know. We need to study this. What do you do? But so in the end game, it's all bro science. It's all anecdotal. It's all just guessing, and it could really hurt guys. But I know about a month ago, a very dear man who's been a patient for a couple of years. He has some depression. We microdosed. We used baby doses of aromatase inhibitors. No, you don't give them to babies. No. We did everything on paper. We had this guy. I had them. You couldn't get better. He still felt badly. End up in the ER with anxiety, and we finally just stopped testosterone.
Wow.
And he's a great guy. If this guy's listening, he's a great guy. I threw the towel in finally. He agreed. I gave him the teeny doses, micro dosing, and it was about 2 years. He has significant depression and anxiety, and even a little bit of testosterone. We tried every. He just has depression, and he said we don't know. We can't manipulate it. I love to see the comments on this. Please give me some ideas. I don't want to just. And he's already been on every antidepressant under the sun. And I'm not putting down psychiatry, We can't. We're limited, Ron. We're limited.
I've never heard of anyone. Obviously, I don't have that much experience in this like you do, but I've never heard of testosterone instigating depression. while
Well,
you're on it. Maybe when you stop taking it,
no,
obviously.
oh my God, it can worsen. Oh, so I have some patients that have massive clinical institutionalized depression.
Oh, goodness.
And yep, it can make them, it can, and there's mania, Ron, there's mania. These guys have bipolar depression. Ron, this is complicated, man. That's why I love taking care of guys as a real doctor, that I don't know something. I have to work with psychiatrists, endocrinologists, urologists, surgeons, GI. I mean, this is like anti-aging. We're fucking losers.
Oh, my God. Okay, let's move on. So this guy just had a comment. He said, I took anastrozole due to, I guess he says he was on 500 milligrams a week of test, took a low dose of anastrozole, 0.25 every other day. That's milligrams, 0.25 milligrams. And I was getting severe headaches to the point of nearly wanting to cry and punch my head for the pain to go away.
I don't see. These are this is what you hear, though. It doesn't make sense, but someone's going to rip him apart. Like, you're a bullshit guy.
Yeah, you didn't really have headaches. You're lying.
I mean, we just had a guy in here with some stomach problems, and it doesn't even make sense. And I just want to try to help him out. But sometimes we just go like this. We don't know what's going on. But those are real, though, Ron. Those are real symptoms.
Wait till this guy. The next one was even. Wait, this guy had a much worse experience. I used Arimadex 1 milligram every other day a while back. Went on a 250 milligram a week dose of test. It crushed my estrogen. I suffered a kind of depression which wasn't typical. I would have a few hours every so often where I'd plummet into depression. I cried a lot, but would within a few hours recover. I would feel overall slightly depressed, but there were these roller coaster dips. It was weird. I also had no libido, none. Some erectile dysfunction, but zero interest. So after blood work, I backed off to every third day and then every fifth day. Barely made a difference in my symptoms, and my blood work stayed extremely low. I bumped up the testosterone and added nandrolone. That fixed my libido. But overall, my experience with Arimadex was a lesson learned. Whilst they do work, they are way too powerful for moderate doses and or long-term use. My belief is a man who has elevated estrogen, mine soars on even 200 milligrams, it's because I'm very obese, should use this drug, but it's something like 1/10 milligram every few days. So apparently this stuff is a lot more potent than just about anything we talk about.
But some guys, Ron, will just take the stuff and feel phenomenal on it. There's so many different men, though. This is what I see. I'm trying to, Ron.
Yeah.
Take-home message is it's very powerful. I use it for guys. I take my average dose is like, I try to lower testosterone as low as I can. They still have a little conversion. I don't want to do it forever, but guys say, Doc, can you please? It does help me. And I do like 0.5, like twice a week. Yeah. And then, boy, man, on a little dose of testosterone TRT, that keeps it really 90% of guys are perfectly balanced. And then obviously they feel sustainably really good. I keep checking it hits the HDL, but as long their hearts are good, I would never do it to a guy that has known heart disease. I just won't do it. I just say, I'm sorry. I apologize if you're going to be upset with me, but I don't feel comfortable doing it. These are guys that don't, and they rock on and they feel good. And these are regular men like you and I that don't have depression, and they're just the average bear guy.
The average bear.
Those questions you're seeing, those comments, are not the average bear.
Okay, so I saved this one for last. It's about HDL. I didn't give you any warning. You had no time to prepare for this question. But he's challenging you, Doc. Why are you so concerned about HDL when the American Heart Association sees no HDL as non-protective for heart disease? Look at the newest guidelines. People with high HDL had the same percentage of heart attacks as people with low HDL. Look at the guidelines.
Okay. I actually, you know what's funny? I copied that, and I was going to send it to my lipidology cardiac expert, and I'm too busy. I literally took a snapshot of that, and I was going to send it to my go-to guy, and I never did, so I'm a little bit shit. Let me see if I can go for that. So the American College of Cardiology, American Heart Association, is the top organization in the world for the heart. They're revising their data constantly. They base it on Framingham, which is old-fashioned Framingham data that's 70 years old now, and they're still using it. And that's looking at people and making a 10-year prediction based on their data, on their risk factors. If they're going to have a heart attack, what's their risk in 10 years? That's called Framingham. And it's you're a man versus a woman family history, age, smoking status, and then we look at diabetes, hypertension, inactivity, and then we do all that to look at the LDL, predict, and then we take the LDL down with drugs, bad drug, statins, and we have new PCI. So now the HDL, sir, the HDL is definitely an independent risk factor for ensuing heart disease. There's no question. I don't know what he's talking about, and forgive me. I'm not a cardiologist, but I'm a testosteronologist. I work in the end, try to prevent. If I don't know something, I refer it to a cardiac expert.
Is he referencing like one recent study, maybe?
It might be, and I think what he's saying is, and I agree with him. I'm agreeing with him that the myth, the cardiac myth, it's called now, that fats lead to heart disease is not true. Now, I agree with you, sir. Here's the bottom line. There's no question that I could say this and no one's going to argue me. HDL is an independent risk factor for having a heart attack. It's one of like 20 though. It's in the top 10, I assume, but it's squirrely. There's so many variables, and when you look for HDL and LDL ratios and other atherogenic particles that lead to heart disease, like Lp(a) and apolipoprotein B, we're trying to look at blood pressure, cholesterol, diabetes. That's all I do. Testosterone gets guys into me, but in the end of the day, I just try to protect the heart so they feel great and they just don't die, obviously, from premature heart disease. So, sir, to lower your HDL knowingly with this drug is unethical and definitely going to be damaging. No one is going to argue me. There's no legitimate doctor that's a cardiac expert, internal medicine doctor, cardiology doctor. I'm not a cardiologist. I'm an internist. Yeah. So there's not one in the world. They're always reviewing the data. So okay, the HDL in some study or in some perspective, maybe we're not sure about the weight of it, but it's got importance, and I want to get everything perfect. Everything. I want LDLs to be as low as they can naturally with diet and exercise, maybe medicines if we need them. I want HDLs to be as high as they can to feel good, and I want cholesterol, other parameters to be proper. If you have bad genetics, protect you any which way I can. So we know that we don't like, in 10 years from now, am I going to eat my words and say that aromatase inhibitors are okay because they're actually protective or something? But sir, I don't know. We don't know. The dogma, the HDL tanks, and it's still going to be an independent risk factor.
That's what he's saying, and I wish he had given the source, because he's claiming that people with high HDL and people with low HDL have the same exact heart attack risk. So I wonder where that comes from.
First of all, I want to see the studies on that, and I'm going to have to run this by my cardiac guy, because I'm out of my league on this. I don't
reference. Know. We'll tackle that, because it's kind of important.
But if this guy's listening, or someone knows this guy or something, please, can you make a comment, sir? Please, can you be more specific and tell me, like, are these the current guidelines? And I apologize for being so busy, but I'll look. I'm going to call my guy. Maybe I'll get my guy on the show, because he did the video. If you go to Metabolic Doc YouTube, I did an interview with this guy. He's a cardiologist. About a year ago, asking about testosterone. Does it cause heart disease? Because the feds say it might. And he answered those. He was very, this guy's very politically correct, but he's very eloquent speaking, very smart doctor. And he told us right on camera, the data for this is weak. There's no data, but we've known this, Ron, for TRT. There's really, we're in a controversial period right now that we don't really know. If you have low T, you're definitely at risk for heart disease. But is that cause an effect? Or if you're an older guy and you have low T because you're just really a sick guy, you're going to die, of course. So it's not a surrogate marker. So, but taking care of men on testosterone like I do all day long, I have to look into all the risk factors, including HDL, but I'm really looking at 20 risk factors, and I just try to do the best I can without hurting someone.
That reminds me of, I don't know if you told me or someone else told me, the highest risk factor for cancer by far is getting older.
Living. Yeah, I
Living.
just funny. Yeah. It's just true though. I mean, so and why would you want to accelerate that with any agent?
True.
But quality of life is everything. I like to be big and badass, and maybe I'll come back to bench some big. I can't mountain bike anymore because I get there's too many injuries. I decided so.
Yeah, I mean, it looks pretty dangerous to me. So.
It's pretty crazy, but it's so freaking fun. But you know what though? But so we just want to live and just. But the heart it's incredible, isn't it? Though there's so many risk factors, but there's about top 10 for cardiac disease, the blood pressure, the cholesterol. If you talk to the experts, they're going to say the leading risk factor medically, the leading for heart disease beyond living long and being a man and bad genetics is cholesterol. And it's bad. It's LDL and HDL ratios. And there's this data. I don't think they're going to be reversing that data, but I'd like to see what that guy's talking about.
Yeah. Well, if you're listening, Mr. or Sir, as the doctor always likes to say, Sir, please give us an idea where that information came from. A link, maybe, if you have a link, would be great. Doctor would like to take a look. I'm curious myself now, because imagine if we found out, doesn't matter what your HDL is, doesn't matter. Has no impact on your cardiac health at all, HDL. So I'd be interested to see about that. Okay, well, Doc, that wraps up another fine episode of Ask the Anabolic Doc. I almost said Ask Dr. Testosterone. Ask the Anabolic Doc.
That's so funny.
With Thomas O'Connor. Check out his website, anabolicdoc.com. More so the mainstream one, metabolicdoc.com. You don't want to get busted.
Testosterone now.
Is that going to be another website?
We have one website, but all the main URL is testosteronology.com.
Testosteronology.com.
Is that awesome?
You should make shirts up or something.
We're going to do it.
The YouTube channel is Anabolic Doc, and Amazon is where you can buy this, as well as his websites. America on Steroids, A Time to Heal. Great little book. Quick read. I read it in about 3 days, and I'm not even that fast a reader, really, believe it or not. So, Doctor, thank you for your time, your expertise, sharing your medical knowledge with the world, to the men who need it out there. You're a very scarce resource, and I'm glad we have this opportunity every week to talk to you.
Muscular development always been good to me.
Cool. And that's right. I got to remind people every month in the pages of Muscular Development print magazine, Dr. O'Connor's column is called Ask the Anabolic Doc?
No, I think just Anabolic Doc.
Anabolic Doc. I know I should know this, but I talk to you every week. I don't need to read the column.
The digital is so much bigger, but they still. I mean, you guys still do a beautiful job presenting that magazine. It's so great to see it still.
I still like to hold things in I'm an old man. I like to hold books and magazines. It's never going to change.
Nice to read.
Yeah, I don't want to. If I read on this for like more than two or 3 minutes, my eyes start getting blurry. I'm like, oh.
Hopefully the magazines will come back, but probably not, though.
Nah. Anyway, thanks everybody for watching Ask the Anabolic Doc with Dr. Thomas O'Connor. We will get you next time.